You're listening to Medscape's In Discussion series on systemic lupus erythematosus, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Maureen McMahon. Dr. McMahon is a professor of medicine and associate chief of rheumatology at the David Geffen School of Medicine at UCLA. Relevant disclosures can be found with the episode show notes on medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for U.S. healthcare professionals.
Hello, I'm Dr. Maureen McMahon. Welcome to the Medscape In Discussion podcast series on systemic lupus erythematosus. Today we'll discuss reproductive health and SLE with our guest, Dr. Lisa Sammaritano. Dr. Sammaritano is a professor of clinical medicine at Weill Cornell Medical College and an attending rheumatologist at Hospital for Special Surgery in New York City. Thank you for joining us today.
Thank you for inviting me.
What I didn't mention in the introduction is that you're the lead author on the American College of Rheumatology guidelines for reproductive health in patients with rheumatic diseases, which I have found incredibly helpful in my practice. So I'm really excited to talk to you today about this. Many of our patients with SLE are in the childbearing years and the reproductive years, and so this can be a particularly important topic to them. But I know in a busy clinic visit where you're worried about their nephritis or there are other things that are going on, we don't always address it with our patients. So I'm just wondering what you usually do about talking to patients about issues related to reproductive health and how you usually bring up the topic, et cetera.
I agree with you. It is an incredibly important issue. Not only are many of our patients within that reproductive window, but most of our patients are women. And so it really applies to many, many of our patients. I usually bring it up in an initial visit. I just mention that this is an important part of their health in general, that disease activity and certain medications can have an important impact on any pregnancy outcome. And it's important that people be aware of that at the start when they're not necessarily thinking about pregnancy. So I usually will just say this may not be applicable right now, but it's important that you know, and then just go over things very briefly. One thing that has been suggested is use of one key question, which is a published tool asking, would you like to be pregnant within the next year? And that's easy because it's very quick. And when physicians or clinicians remember to incorporate that, it is very effective in terms of helping to focus the patient's thoughts. If they absolutely do not want to be pregnant or are not sure, that then can lead into a quick discussion about contraception. And, we have been focusing, we meaning rheumatologists in general, in recent years on trying to document form of contraception used and counseling. And I think there have been many efforts at many centers across the country to try to identify which patients are and are not using contraception, to counsel them regarding that. So that's one way that this discussion can go. The other way is if patients say, yes, actually, now is the time that I am thinking of becoming pregnant, then we can at least do some preliminary counseling and give them, I think, our general guidance, which is that for women with lupus who are considering pregnancy, it's important that their disease be well controlled, whether remission or a low level of disease activity, for a period of around 6 months before conception, and stable on pregnancy compatible medications. I know that's a mouthful, but that really is the big point from the reproductive health guideline. Activity of disease is incredibly important in terms of outcomes for pregnancy, not just for the health of the mother, of the patient, but also for the outcome of the pregnancy itself. And I really try to emphasize that to women, because I think often women are willing to sacrifice their health if they think that they will have a successful pregnancy, because it is such an important thing for so many of us. And so, it really is important. It is about your health, absolutely. And that is really important. But also, if you want to have a healthy baby, it's important for that too.
it is so important to bring it up with patients early on, because I think that once we bring it up, then even if it's not a conversation they want to have right now, it's a conversation that can recur over time, and so that planning can really happen.
I think one other benefit of not just the ACR reproductive health guideline, but all of the other publications and
Mhm.
guidelines. EULAR just published a medication and pregnancy guideline this year. The importance is that now all rheumatologists, not just those who focus or specialize in this, have easy access to data that they can relay to their patient, because it is not possible for every woman with lupus thinking of having a pregnancy to go see somebody who just specializes in that. We all see patients with lupus. We all are going to have to counsel them about pregnancy, contraception, and other reproductive issues. And to have ready access to guidance for that, I think is
Yeah, I
important.
really think so too. And again, I think it's even for those of us who see a lot of these patients, I think it's helpful to have that official
Yeah.
guidance as well. In terms of contraception, how do you usually approach that for your lupus patients?
It is similar to the discussion about pregnancy planning and obviously closely linked. If we counsel someone to avoid pregnancy because their disease is active or because they're taking a teratogenic medication, that's not enough. We need to help guide them, because not all contraception is as effective or as safe as we would like it to be for our patients. I tell them that there are different forms of contraception that may or may not be best for you. The general recommendation that we have made in the guideline is that so-called LARC, long-acting reversible contraception, is what we recommend for all of our patients, actually, with rheumatic disease, not just with lupus, regardless of whether their disease is active or quiet, regardless of whether they have antiphospholipid antibodies or not, regardless of whether they are on an immunosuppressive, and regardless of whether they are nulliparous, that is, have not had children. And so the LARC contraceptives are highly effective. That means chance of pregnancy is less than 1 per 100 patient years. And the LARC contraceptives are IUDs and the subdermal progesterone implant. We know less about the implant than we do about the IUDs. And so in our guideline, we actually recommended IUD over implant just for that reason. There's so little data on use of any contraceptive method in patients with lupus and or APS. So we really have to extrapolate somewhat from the general literature. There's a fair amount of literature on use of certain contraceptives, specifically progestin-only contraceptives, in patients who have other prothrombotic conditions. And so we have looked at that literature in formulating our recommendations for our APL positive patients. So, first and foremost, we really recommend use of an IUD. And I usually recommend the progesterone containing IUD because I think it has a lot of advantages. One advantage is that just for anyone using it, it can decrease menstrual cramps and menstrual bleeding. That can be a big benefit for women on warfarin because of APS, because their menses otherwise can be quite heavy and lead to anemia. The progesterone is really very local in its action, so minimal systemic side effects. There are actually varying formulations. So there are smaller ones with less progesterone that can be used in adolescents or teenagers. There are a lot of options for that. And there are studies that show that these progesterones do not lead to an increased risk of thrombosis, unlike the estrogen
Right.
containing ones. So, for lupus patients, regardless of their activity or APL, we really recommend the IUD. Now, some people don't want an IUD, and that is understandable. If a patient really doesn't want an IUD, they shouldn't have an IUD. We need to then figure out another option for them. And then what we do for our patients with lupus who do not have antiphospholipid antibodies is look at their level of disease activity. If it is quiet, meaning either remission or low level disease activity, they absolutely can consider use of an estrogen progesterone contraceptive. Usually that's the pill. And we avoid that in patients with moderate or active disease because the studies that confirmed no extra risk of flare, including the Selena study, excluded those patients. We can't say that for sure it's a bad thing. We can only say we have concerns because it hasn't been studied. And the whole reason for the Selena study was a long held belief that estrogen would cause flares. So we're very careful in that way. And for our patients who have active disease or who have APL, we recommend they avoid estrogen. And if they are not comfortable with an IUD or an implant, they can use a progesterone only pill. It is effective, moderately effective. So risk of pregnancy is like 1 in 20 patient years instead of 1 in 100, but it's effective, especially with consistent use. And I guess the last thing I'll say is that for someone who really isn't comfortable with any of these things, and I have absolutely had patients who feel that way. I don't want any hormones in my body. I don't want anything foreign in my body. Then we tell them to do the next best thing. And that is okay, use the least effective, but maybe use two forms. So condoms are least effective, but they're a whole lot more effective than no contraception. There are other low effectiveness forms of contraception that can be incorporated. You can use it with spermicide. You can use it with the rhythm or natural family planning method, right? So just timing things. And then one final note on contraception is that we also emphasize that emergency contraception, that is the morning after pill, is safe for all of our patients with lupus, whether they have active disease, whether they have antiphospholipid antibodies. And I try to make a point of mentioning that to my patients because I don't want them to have to rush to reach out to me in an urgent
Right.
way when it becomes an acute issue. It is just a progesterone and it is fine for all of our patients to take. It's over the counter and they should absolutely be aware of that, that if they feel they want that or need that, it's
That's
okay.
great. I think that's a really helpful point. So, when you do think about having a pregnancy that is planned, what are some of the considerations? A patient comes in and says, "Okay, now I'm ready." What are some of your considerations, both with timing and then what kind of testing do you do, or what other considerations do you keep in mind?
For our patients with lupus, it really is very important that they have quiet or a low level of disease activity. So I go over that with them, and it's interesting because when we wrote these guidelines, we said quiet disease. And patients will say, well, what does that mean? And it's a good question, right? If I have a little bit of a malar rash and I always have that, can I never get pregnant? Or if I have stiffness and a little joint pain when I wake up in the morning, does that mean my disease is active and I can't get pregnant? The answer to that is no, a low level of disease seems to be fine. And actually, there were several publications that came out after our guideline was published that sort of looked at low level of disease activity specifically, one of which said, you know what, outcomes are the same, whether you enter pregnancy in remission or whether you enter pregnancy with a low level of disease activity. So we usually say around 6 months of things being stable. Does that mean they have to be off medications? Well, means they have to be stable on pregnancy safe medications, which is one of our next important concerns. For lupus patients, really the most common issue is going to be
Right.
mycophenolate because we use it so much and it's so effective. In that case, we transition them to azathioprine as our first line substitution. And importantly, we need to check and make sure that they do well on it, that their disease doesn't flare, and that they tolerate it, that they don't have side effects over those first few months. So I usually give them like 4 months of azathioprine before saying, okay, I believe that this is working for you. It's okay now to start trying. There are many other teratogenic medications to look at. Certainly for patients with antiphospholipid, if they're on warfarin, they will be changed over to usually low molecular weight heparin. And whether that is done while they are trying or when they first have a positive pregnancy test is often up to the rheumatologist and the maternal fetal medicine doctor. If it's anticipated that it may take them a long time, they may want to continue with the warfarin and then, make a quick change. Other things that we look at, although it isn't common, thankfully, for women to have such severe damage from their lupus that it precludes
Mm.
pregnancy, there are going to be some women who are unfortunately in that position. So, someone who has a creatinine clearance in the 30s because of prior lupus nephritis doesn't matter if the lupus nephritis is now, long quiet, they still shouldn't attempt a pregnancy because of the risk to them. The risk of going into complete renal failure is quite high, and the risk of losing that pregnancy because of inadequate renal response. The normal response during pregnancy by the kidneys is to increase the GFR by 50%. Or if someone has, for example, pulmonary hypertension, we know that's a big risk factor for maternal morbidity and mortality in pregnancy. So for those few patients, we do counsel them to avoid pregnancy. There are other options, and we'll get to this, I think, but certainly those might be patients who may be able to undergo IVF. And if financial, social, other circumstances permit, including their preference, may be able to use a gestational surrogate to have a biological
Sure.
child. And then finally, as you mentioned, there are antibodies that we check. We check antiphospholipid antibodies if we don't already know about them, and there's no need to keep checking them during pregnancy because it's unlikely that they'll change. If someone has positive antiphospholipid antibodies and no history of obstetric or thrombotic complications, we just keep that in our awareness and we follow them carefully. All of our lupus patients are recommended, lupus and APL positive, to take low dose aspirin during pregnancy to help prevent preeclampsia because of general population data that says that for those people who have some risk factors, it does lower the risk of preeclampsia. And then for those who have a history of obstetric manifestations, we will recommend aspirin along with prophylactic low molecular weight heparin. Obviously, thrombotic complications, they'll get therapeutic. Finally, I'll just touch on the other important antibody, which is, of course, anti-Ro or
Right.
SSA. We do recommend checking that in all of our lupus patients since we anticipate about a third will be positive. It is, I think, important to know that because at the very least, we can do some monitoring. We do recommend, though, if the patient is not already on hydroxychloroquine and assuming they can take it, that there are no allergies or contraindications, we recommend they take that. Both, I mean, really for every lupus patient, but specifically for those with these anti-Ro antibodies because of data that suggests that it may decrease the risk of developing heart block. There are controversies about monitoring in this area. And I guess the important thing to know about that is that, the Maternal Fetal Medicine Society pulled back from recommending fetal echocardiograms during pregnancy, citing the lack of evidence of efficacy of treatment for first or second degree heart block in preventing third degree and the potential negative side effects of administering dexamethasone during
Mm.
pregnancy. There are data that suggests that there can be long term implications for neurodevelopmental issues in the offspring. However, most rheumatologists who are experts in this area and pediatric cardiologists are still sticking with both the monitoring as well as the consideration for dexamethasone therapy if certainly second degree heart block is identified. And the nice thing is that there is a study in progress, the Stop Block study, being done by many individuals, but with the PIs being Dr. Bayan and Cuneo, that is looking at home monitoring for PR interval in women with high titer anti-Ro antibodies. So the advantages here, we've long known that when this happens, it can happen really quickly. A week between fetal echoes or 3 weeks between fetal echoes, it just may be too late. They have women testing themselves at home 3 times a day during the most important period where we think this happens, 18 to 26 weeks. And then that is confirmed by a pediatric cardiologist if abnormalities are found, and they are whisked off to have a formal fetal echo. And actually, if second degree heart block is confirmed, they are given immediate treatment with dexamethasone and IVIG. What we know from preliminary results from that study that really can impact our counseling for patients now is that really it takes, for the most part, it's a high titer of Ro antibody that gives you this great risk. In the commercial assays where less than 1 is negative and it goes up to greater than 8, that means that really greater than 8 is likely to be the higher risk category. So I think it is helpful for patients to know that if they have a value of 1.5, that is very unlikely to put them at risk. The other thing we know is that this monitoring can identify. I mean, they have shown that it correlates, it performs well. So it does present a really promising alternative for the future.
That's great, and great to know about the Stop Block study as well, because I'm sure there are a lot of patients who would be interested in participating in that. I did want to touch on considerations for our patients who are interested in undergoing assisted reproductive procedures, because I think that that's coming up more and more frequently in our population.
I think it's a wonderful option for our patients. Briefly, the considerations are really the same as the considerations for pregnancy because that's the intended result. So, quiet disease going into it, appropriate use of low molecular weight heparin if patients are APL positive or have APS. And I would say for those who are going through with IVF with plans to transfer an embryo and embark on pregnancy, obviously they have to be on the appropriate pregnancy safe medications. Patients do have options today that they didn't have 20 years ago. Even a patient who doesn't have a partner that, whose sperm she wants to use to fertilize her eggs, these patients can now freeze their eggs in a safe and effective way that wasn't possible in years past. It used to be they could only freeze embryos. So I do have patients who are on mycophenolate who know that they need the mycophenolate. They can't stop it, or even we don't want to take a chance with changing right now because perhaps they're in the midst of treatment for their lupus nephritis and we want them to have the most effective therapy, but they're 38 years old and they want to be pregnant. So, a great option is for those patients to undergo ovarian stimulation and then freeze either embryos or eggs for use in a few years when it's safe for them. The procedure itself is much safer now than it was in years past. I always have a discussion with the reproductive endocrine doctor to minimize estrogen peaks as much as possible. But overall, we think that for most of our patients, this is a very feasible way to either attain pregnancy if there have been fertility issues or perhaps to prolong or protect their fertility.
And then finally, just to kind of round out the spectrum of issues for our patients, how do you counsel patients on hormone replacement therapy?
As you know, hormone replacement therapy has had so many highs and lows over the past 50 years. When the Women's Health Initiative study came out in the early 2000s, it essentially stopped being given because of the concern for breast cancer, for cardiovascular disease. But then subsequent analyses of that data and further controlled studies showed us that it wasn't so simple, that it really depends on the person, their risk factors, and where they are in their reproductive lifespan. So those studies were giving hormones to women specifically to see if it helped cardiovascular health because of earlier studies that raised that possibility. So the women who were getting the hormones were 60, 70, the mean age, I think, was like 70. Now we know from further reanalyses and further studies that there seems to be a window of time where it is not harmful and perhaps even beneficial for cardiovascular health. And that is for women who are immediately postmenopausal, so within 5 to 10 years of menopause, and who are less than age 60, and who do not have significant risk factors for breast cancer or cardiovascular disease. So that's all general population information. So that, of course, we adapt to our patients. So I will tell my patients that right now, this is recommended only for women who have severe vasomotor symptoms. Their function is being limited by these hot flashes. In addition, we have to think about specifics due to lupus. So very active disease, we would say no. And again, the other SELENA study did find a small increased risk of mild to moderate flare in lupus patients with taking HRT. So that is a discussion. For APL positive patients, that obviously should not be taking estrogen. And that is hard for people who have these severe hot flashes or other vasomotor symptoms. If a person is thinking about taking this because of genitourinary symptoms, vaginal atrophy, frequent UTIs, we do think that intravaginal estrogen, which has really predominantly local effects and is very effective for those symptoms, is okay for positive APL patients. And there is now a recently FDA-approved centrally acting drug that works well for hot flashes that is not a hormone. It has risk of LFT abnormalities, and so it's not something that you want to give everybody who's had one hot flash. But for someone who really is debilitated, I think it's a wonderful option for our APL-positive patients. And that, I think, was just approved last year in 2024.
I think it's great that even our APL positive patients do have these other options for when they really do have debilitating symptoms. I want to thank you so much, Dr. Sammaritano. I've really enjoyed our discussion today, and I think it'll be really helpful for, all of us who are dealing with patients who are in this age range and have issues. Thank you for joining us. Please take a moment to download the Medscape app to listen and subscribe to this podcast series on systemic lupus erythematosus. This is Dr. Maureen McMahon for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Systemic Lupus Erythematosus podcast series with our host, Dr. Maureen McMahon. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on systemic lupus erythematosus.